Welcome to everyone signing into this webinar with the National Academies of Sciences, Engineering and Medicine and the Consortium of Universities for Global Health. This webinar is on global health and the future role of the United States and is part of a series of webinars that CUGH runs with its members, partners, and collaborators on important global health issues. The National Academies of Science and Engineering and Medicine have put forth this very important document that you can access on their website at the National Academies, or you'll find it on CUGH.org, CUGH's website. The U.S. has been a global leader in global health, providing both financial and political support for an array of important global health initiatives. They have received bipartisan support across many administrations. This report will provide guidance to President Trump, his administration, and Congress, and deals with very important opportunities for the U.S. to continue and maintain its leadership and delve into new areas to be able to improve the health and welfare of people around the world and in the United States. We're pleased today to have three of the committee members, Amy Batson from PATH, Leah Haskins-Bernald, professor at the University of California at Berkeley, and Dr. Michael Mearson, professor at Duke University. First up today is Leah. Leah Fernald, thank you very much for being here. The floor is yours.
Thank you so much. As a point of introduction, I would say the United States has long been a leader in global health, and that we have a large motivation to invest in global health for two key reasons. First is to secure protection against global health threats. Second is to promote productivity and economic growth in other countries. While the burden of infectious diseases rests predominantly with low-income countries, these diseases represent global threats that have dire consequences for any country, including the United States, in both human and economic costs. And there's an increasing prevalence of non-communicable diseases that has also negatively affected global economies, threatening societal gains in life expectancies, productivity, and overall quality of life. Against this backdrop, the committee for the development of this report was comprised, and if you go to the next slide, you'll see a list of the committee members. The co-chairs were Jendai Fraser and Valentine Fuster, both of whom led the charge, and then there was an array of participants from private sector, public sector, and universities, representing a whole range of expertise in the world of global health. Next slide. The committee process involved 4 deliberative committee meetings beginning in September of 2016. The first 2 were open for information gathering and public comment, and then the remaining meetings were closed to committee only. There were portions of the earlier meetings that were also closed to committee. The committee incorporated a wide range of information, some from Survey Gizmo from 40 CDC country directors and 12 USAID mission employees, and lots of other information from existing academic literature, research reports, gray literature, and a wide range of other sources of information. The report is 10 chapters, and it underwent expert review by 17 experts who provided a great deal of feedback, and that feedback was incorporated into the final draft, which you can have access to. The study sponsors, that's the next slide. There are federal sponsors and private and philanthropic sponsors that you can see on the slide. USAID, CDC, the FDA, NIH, and PEPFAR were the federal sponsors. And then there were private and philanthropic sponsors, including Becton Dickinson and Company, Medtronic Foundation, the Merck Foundation, and the Rockefeller Foundation. So before jumping, oh yeah, go ahead.
No, go ahead, Leah. This committee had a daunting charge, which was to be assessing the global health landscape and to be making recommendations on what were the future priorities for not only USG attention, but how USG could also be fully leveraging the U.S. global health enterprise, and ways to be both targeting efforts on some of the most important domains for health impact, but also ways to be improving responsiveness, coordination, and efficiency. The committee was also asked to be considering relevant global changes that would have an impact on global health, including globalization, the change from the MDG agenda to the SDG agenda, the increasing privatization of healthcare and the increasingly important role that private sector played in assuring healthcare, importance of NCDs and others. The committee was quite clear from the get-go that it would not be able to address every important issue associated with global health, and so worked hard to be setting priorities based on where we felt there could be highest global health impact and where the USG was best situated to be helping to drive forward that impact. Next slide, please. The key messages from this report that we will be discussing in detail over the next hour with you, were first around the priority health areas for attention, achieving global health security and recognizing that global health security is also U.S. health security, ensuring a maintained and sustained response to the continuous health threats such as HIV, AIDS, TB, and malaria, which will resurge if there is a drop in efforts, ensuring that we save and improve the lives of women and children and build upon the incredible progress that's occurred to date, and promoting cardiovascular health and preventable cancer, so beginning on this NCD agenda. The report also highlighted the importance of how the U.S. does business in global health to better enable innovation and most effective use of the resources we have available. And in the innovation space, it was looking particularly at accelerating the development of key medical products such as vaccines, drugs, diagnostics, and devices and tools, but also looking at the innovation space of information technologies and how we can enable more harmonized digital health infrastructure for impact. We looked at optimizing of financing strategies, so how money is being used and where it is coming from, and of course maintaining U.S. leadership in the global health architecture as we work with both national, bilateral, and multinational partners around the world. The last key message was around the recognition that driving health impact requires an integrated approach as opposed to simply a vertical disease approach. The importance of investing in capacity to help support that more integrated approach that links together how we tackle all diseases and all health domains. And of course the critical importance of partnership, working in partnership with partners in the U.S. and with partners around the world. Next slide, please. This slide shows you a nice schematic of how the report is structured, and I think that also aligns very well with our key messages. So first, we looked at the health areas, the priority health areas for investing in basically two buckets. One was how do we best secure against global threats, noting that that is both the global health security agenda, the pandemic and epidemic agenda, as well as these continuous communicable disease threats and their risk of coming back. And then the second bucket around how our investments help to enhance productivity and economic growth, both through saving and improving lives of women and children, and through promoting cardiovascular health and preventable cancers. The third component that you can see in that red arrow that cuts across both of these was this recognition that how we invest, who we're engaging with, how we do our work, and we can maximize those returns. We can increase the impact of our human and financial investments if we focus on sort of three particular domains. One is how we are catalyzing innovations. So innovations to address each of these different health priorities. How we think about financing and smarter financing in terms of who, how, and how it is aligned for impact. And third, how we approach the global health leadership question and the extremely important role of leadership that the U.S. has played to date and what this means in the coming years.
Great. Thank you very much, Amy Batson. Now, Mike Grierson is going to discuss some of the report details. Mike, over to you.
Okay, thank you. So I'm going to cover two of the priority areas under securing against global threats. The first, global health security. all of you are well aware, we're on the heels of an Ebola outbreak in DRC, yellow fever resurging in Brazil, MERS in the Middle East, cholera in Yemen. We could go on, and certainly these threats will continue. Many of them, of course, are related to organisms that are a result of zoonotic spillover. We have the constant threat of influenza, right now H7N9 outbreak in China. And then, of course, we have the growing problem of antimicrobial resistance, with a projected 300 million deaths from resistant strains by the year 2050. We have many vulnerabilities, and particularly poor health infrastructure and preparedness, vulnerable supply chains, and slow medical countermeasure development. And of course, we have fragile states that are quite vulnerable to these infections. Our challenges include urbanization, particularly the reduction in biodiversity, and complacency. U.S. funding for public health preparedness has fallen each year since 2002. We have the challenge of cross-country partnerships. Pathogens know no borders. Viruses don't need passports. And the big issue that we faced recently is with leadership and division of responsibilities within the United States. We lack strong leadership and a defined chain of command that we need often in such emergency situations. Next slide, please. So our actions are on two fronts that we recommend. One is on the domestic front. The committee called for a new proactive approach for public health emergencies, embracing prevention and preparedness, and there were three components. One is the creation of a single coordination body, or if you like, an international response framework like exists for FEMA, to guide international public health emergency responses. Secondly, a dedicated funding line for domestic preparedness, response, and medical product development. We certainly don't want to see a repetition of what happened with the need for Zika funding recently that took 7 months to find the funds out of the Congress. And then thirdly, improved coordination with multilateral organizations, particularly supporting the global health security agenda. And on the second front, next slide, please, on the international front, here we called for building core preparedness capacities and public health infrastructure internationally. In particular, CDC, NIH, and here I'd cite the Fogarty Center in particular, Department of Defense, USAID are all part of this to expand training and information exchange efforts to increase capacities in low and middle income countries to respond to public health emergencies. The continued aligning with effective multilateral organizations, and then a much more coordinated and dedicated effort to combat antimicrobial resistance. Next slide, please. The second area of continuous threats, we focused on HIV, AIDS, TB, and malaria. You can see on this slide that since 2000, there have been significant increases in incidence and mortality of these diseases. But we know that there were 2 million HIV infections in 2015, 10.4 million cases of TB, and 212 million cases of malaria. So the problem has not gone away. The challenges in AIDS are known. Only 60% know HIV status. 50% of cases that need treatment are getting it. TB remains a leading killer with increasing resistance and spread of TB. And malaria, we have the constant threat of drug and insecticide resistance. Next slide. So here, the committee had three main recommendations. One on AIDS, that PEPFAR should be funded at current levels, but with more flexible funding targets. It should continue transitioning to national government, adapt its platform to focus on chronic care, place stronger emphasis on prevention, including interventions targeting gender-based violence. One thinks in particular of the DREAMS project in PEPFAR. And of course, we called for the Global Fund to continue to be supported. In tuberculosis, we called for the CDC and NIAID and USAID to conduct a thorough global threat assessment of TB and execute a plan for developing and investing in new diagnostics, drugs, vaccines, and delivery systems. And for malaria, we called for the government to continue its commitment to fighting malaria through the very successful President's Malaria Initiative.
So this is Leah. I'll talk about the challenges, the current state and challenges in women's and children's health and our recommendations. So first, to start with the current state, we really focused on women and children as the linchpin of healthy and thriving societies. As a point of reference, the MDGs were adopted in 2000 to set the first global goals for women and children's health. And the good news is that global mortality rates for children under 5 have been cut by more than half since 1990, and the maternal mortality decreased by nearly half. But in spite of this progress, none of the maternal and child health related goals were met by the time the MDGs expired in 2015, and that remains a critical unfinished agenda. So we still have nearly 6 million children and more than 300,000 mothers dying each year, and these women and children are dying from mostly preventable causes, such as lack of access to skilled birth attendants, preterm birth, or respiratory infections for newborns. In addition to the mortality issue, we have the problem that almost 250 million children fail to reach their developmental potential because of extreme poverty and stunting. And then this suboptimal development leads to poorer health, lower educational attainment, poorer school performance, and less earning power, which can be up to 25% of average adult income, which is lost per year, so that countries can forfeit an extreme amount of GDP because of this lack of investment in promotion of children's thriving and then setting them on a developmental positive trajectory for life. So we identified clear challenges in the current state, and we also identified a challenge, system-level challenges, which is that we often see that women and infant health are delivered separately, and that this can create a burden to patients. So this set the stage for what our recommendations were. Next slide. Which, on the next slide, which is the needed actions, which is really, we categorized into 3 key buckets. The first being survival, thinking about survival, and prioritizing interventions that we know work, such as immunizations, integrated management of childhood illness, nutrition for both pregnant women, newborns, and children, prenatal care and focusing on safe delivery, and then also access to contraceptives and family planning. So these were really part of our recommendation that was around improving survival. We also had a second key recommendation, which has to do with thriving and promotion of thriving. So as I mentioned, adverse experiences during childhood can have long-term consequences into adulthood. And so this early period is very crucial for interventions. And these kind of interventions can include nutrition, reduction of childhood exposure to violence, detection and management of maternal mental health issues, and then also the promotion and support of early education and cognitive stimulation for children. So in addition to the survive recommendation and the thrive one, we have a recommendation about transformation of the healthcare system to support these other recommendations. So, for example, without even having new programs or funding, if there could be greater integration of approaches, I'm still on women's and children's health on the previous slide, 17, or 16, yeah, thank you. So without new programs or funding, integrated approaches through workforce training and partnering with other sectors, such as education and development, can accomplish really many of the survive and thrive goals. So the public-private partnerships, as Mike also mentioned, such as PEPFAR's Dreams program and Merck's Saving Mothers Giving Life program, have shown promising models for improving care delivery for women and children. Next slide, please. Another key area that we talked about in terms of topic was cardiovascular health and cancer. So we know that NCDs disproportionately affect those in low and middle income countries and globally kill 40 million people per year. And 3/4 of these deaths, of the 40 million, occur in low and middle income countries. So if we had increases in the 5 most common non-communicable chronic diseases, we would result in an output losses of $47 trillion by 2030. So the costs resulting from productivity loss associated with disability, unplanned absence from work, and increased rates of accidents are 4 times the cost of treatment for illnesses. So the current state is really quite daunting. We have cardiovascular disease with 18 million deaths in 2015. Costs are projected to rise to more than $1 trillion by 2030, and many symptoms go undiagnosed. Risk behaviors associated with the onset of cardiovascular disease later in life often form during childhood. So we're thinking about the life course perspective here in terms of when interventions really need to be targeted. In terms of cancers, 8.8 million deaths occurred in 2015, and these costs are projected to rise to more than $8 trillion by 2030. And 2/3 of these deaths are really due to late detection. So one key issue with cardiovascular health and cancer is that these diseases suffer from a lack of branding and awareness and an inability to mobilize political will. So we've seen this again and again, which is that because it's harder to recognize, harder to identify, that it just doesn't have the same kind of traction as some of the other conditions. Many health systems in low and middle income countries are not designed to deliver chronic care, and they really lack the physical infrastructure. So these are some of the challenges that we realize that are really very relevant in this space. Next slide, please. In terms of thinking about actions, we focused on priority strategies to ensure the highest impact. So this would be targeting and managing risk factors, detecting and treating hypertension early, detecting and treating early cervical cancer, and immunizations for vaccine-preventable cancers, so HPV and hepatitis B. So our key recommendations were that the USAID, State Department, and CDC should provide seed funding to mobilize the private sector to address cardiovascular disease and cancer. Secondly, that efforts should be coordinated with governments and integrated with existing platforms. This is a very similar recommendation to the one for the women's and children's health. And that we should really focus on behavioral risk factors, smoking, alcohol, obesity, and hypertension, treatment of early cervical cancer, and immunization for HPV and hepatitis B.
Thank you very much, Leah. Before we get to Amy, just for those of you who are online, please send your questions in online, and we should have at least 30 minutes to ask questions of the presenters, and please direct your questions to a particular presenter. Amy, over to you.
Thank you. Next slide, please. So we're switching gears here now, going from these 4 priority health domains to then this cross-cutting recommendation of how can we maximize the returns on U.S. investments in global health and help promote progress or help advance progress in all 4 of these areas. So first, talking about catalyzing innovation. Next slide, please. We know that innovation that provides the tools that enable us to tackle these very difficult health challenges. So getting the right vaccines, next slide please, vaccines, drugs, the diagnostics and medical devices, as well as a new domain of innovation of information technologies have the potential to dramatically improve our ability to prepare and respond to global health threats, and to be able to further our progress with women, children, and these cardiovascular and cancers. However, we also know industry is an extremely important actor in our ability to harness some of the progress of industry and its capacity to take an idea, take the know-how, and actually turn it into a sustainably supplied product is an extremely important role for success. But what we're finding right now is that weak markets, the global health markets outside of the U.S. borders, and costly and lengthy R&D is currently resulting in underinvestment in those types of innovations that best address these neglected diseases and diseases of global health. In fact, estimates are that between 2000 and 2011, only 4% of the new products on the market were addressing neglected diseases. Second, we know that the actual capacity to do the R&D around medical products, most notably clinical trials, in the countries where this is needed is often very weak, and that creates additional challenges and makes the clinical trial process often even riskier and longer. And third, that when we see a new frontier, a new technology of information technology, right now it's being applied in a very fragmented and duplicative approach through sort of small apps, small tools that are very singular disease focused. And so we're not actually taking advantage of the power of information technologies to help address health across all of the key domains. Next slide. So the recommendations from the committee were first around how to help stimulate greater innovations, how U.S. government agencies could help both support push and pull type of mechanisms. Push mechanisms that help to reduce the cost, help to support R&D, and pull mechanisms that help to increase the market incentives, in part by reducing market risks, of developing, licensing, and introducing these priority medical technologies that are needed to address all of our global health priorities. Second major recommendation was that CDC, NIH, and DoD, and here I would particularly call out Fogarty's role, should be continuing and actually increasing its efforts to ensure trained people and resourced institutions, infrastructure necessary for partner countries to be able to conduct clinical trials and partner with other U.S. government and U.S. academic institutions in this effort. Third, recognition that as we start thinking about how to maximize the true potential of information technologies, that U.S. agencies should be working with other international stakeholders to be convening and creating a common digital health framework that is looking at how do we ensure the real-time cross-cutting data collection, data synthesis, smart visualization to enable and to inform decisions at all levels of the health systems. And fourth, that U.S. agencies should be expanding on a principle that was outlined in the Digital Gap Act around how we can be investing in infrastructure in a smarter way, in a more collective and integrated way, so that all groups can benefit and we can actually have a robust platform to be building on. And that we need to be aligning U.S. funding in digital health in order to reduce some of the duplication and fragmentation, which is not creating the greatest benefits. Next slide, please. A second key domain in terms of how we can maximize our returns, increase our impact, is around the issue of financing. And financing for global health has been and is continuing to change very significantly. There's the issue of who pays, what information they need to get that payment, and how financing is structured. On the who pays, one of the most important transitions occurring right now is that many low middle income countries, which have growing economies, in fact economies that are growing faster than many industrial countries, are beginning to transition away from traditional foreign aid and towards domestic aid. They are already financing the gross preponderance of their global health needs, but now even things like vaccines and immunization and introduction of new technologies is being transitioned to these governments. And how we ensure that kind of sustainable financing is a big issue. Second current state is that the way governments are financing is often more focused on shorter-term expenditures and vertical disease programs. That's something that's more attractive and sellable to governments, but in fact, long-term cross-cutting investments can have a more significant return. Third is a growing understanding that more rigorous analysis of not only the health impact, the social impact, but also the economic and financial returns of investments in global health is very important to ensure that funds are used in the best way and to be able to engage new types of funders, particularly from the private sector, impact investors, and others. And the last key challenge we're facing right now is this, that innovative financing mechanisms are being tested. We're seeing some interesting success in how they can increase the value of investment by changing the risk profile, by engaging key players, by leveraging others' financing, and sort of how can we start to scale those up. Next slide, please. So the key recommendations from the committee were first around recognizing then the importance of the U.S. government balancing its funding to have with more weight towards longer term, more catalytic investments. And often this is investments in what could be termed global public goods or sort of shared goods. And so specifically that USAID, state, and HHS should be jointly assessing how they're approaching global health funding and working together to ensure that they are jointly investing in longer term and more catalytic investments that will provide returns not just for one health area, but for all of the health areas. The second major bucket of recommendations was around how the U.S. government could be optimizing resources through what we were referring to as SMART or different financing strategies. So in particular, how USAID and PEPFAR should be structuring their financings to help promote this transition towards domestic financing with greater country ownership for HIV/AIDS and other health domains. Second, how USAID and other entities in government should be expanding the proven innovative financing mechanisms that create more flexibility and that often enable other partners, enable the U.S. government to be leveraging funding from other partners, such as the Development Credit Authority. And last, that the Treasury, State Department, and USAID should be working closely with key partners who are leaders in the financing domain, such as the World Bank, the IMF, the Global Fund, and Gavi, to ensure that those partners are also helping to promote this transition to sustainable domestic financing and helping to attract and leverage alternative financing sources towards these high priority health domains.
Thank you very much, Amy. And to everybody who's listening, Dr. Mearson will finish off the last few slides, and then we're going to go right into questions. Mike, over to you.
Thank you. So the third cross-cutting area was global health leadership. The current state is summarized here. Global governance for health requires involvement of organizations that directly and indirectly impact health. We often forget that. An organization like the World Trade Organization, though not a health organization per se, has a great impact on global health. Secondly, key, obviously, that WHO has essential functions, yet it's of reform and remains underfunded. And thirdly, that that's looking outward. Thirdly, looking inward, that the current U.S. system for health diplomacy is not well suited to global health emergencies. What we have seen is that diplomatic professionals often lack health expertise, and available health professionals often lack diplomatic expertise, diplomacy expertise. We felt that both HHS and the State Department lack a global health track, which results in sometimes a lack of institutional knowledge within both agencies. And this led to our recommendations. Next slide. 3, first, that the State Department and HHS should use their influence to improve the performance of key UN agencies, especially WHO. Our government contribution should come with a requirement that reforms are adopted. Many of you on the call know that WHO selected a new Director General today, Dr. Tedros from Ethiopia, and he will obviously be key in making this happen. Secondly, that state and HHS should remain committed to key global partnerships such as Gavi, the Global Fund, the Global Health Security Agenda, and the new Global Financing Facility. And thirdly, that Congress should amend the Foreign Service Act to enable global health experts within HHS, and that the State Department should create a global health career track to deal with the lack of, in both agencies, of sufficient career individuals in the area of global health. Next slide. To summarize the report is hard in one slide, but here is an effort. Health and well-being of other countries affect the health, safety, and economic security of Americans. We believe that taking a more proactive and systematic approach will make the U.S. government's global health enterprise more efficient and cost-effective. Third, that the U.S. global health strategy should include forward-looking policies, a long-term vision, country and international partnership, and continued investment. More than anything else, the U.S. needs to maintain its leadership in global health. And last, the U.S. can maximize investments by cross-cutting issues that we've discussed in the report, catalyzing innovation, leveraging and shaping financing, and working with governments, industry, and global partnerships. I think there's one more slide, which is if you want a PDF of the report, it's available here.
Great. Thank you very much, Leah, Amy, and Mike. That was fantastic. We're going to go to questions right now, and not surprising, I'm going to bundle a few of these together into the obvious question, which is what advice can you share in terms of how these great recommendations are going to get traction with the current administration and Congress, given the cuts that have been proposed and the cuts that we saw today to NIH. So what's the strategy to get this in front of congressional leaders? Who would like to take that?
Well, this is Mike. I'm willing to start. I mean, obviously, the report is an National Academy of Medicine report, and it at the launch that took place last week, Dr. Zhao mentioned that the Academy was developing a plan for dissemination of the report. Obviously, first and foremost to the U.S. government, planning to meet in the Congress. And and with the executive branches that particularly the ones that sponsored this report. I think there's already been a presentation of the report to them. I think that's the main step that's being taken right now, is looking for opportunities of that nature to create awareness of the report and of course the details to those agencies that are mentioned in the report, asking to take actions in the recommendations.
This is Amy. I would just add that I think that in terms of using this evidence-based report as a tool for helping to create awareness and sort of point in certain directions, that it is it's a collective responsibility, and so would look to many of you who are on this webinar for your suggestions and your active engagement in helping to disseminate some of these findings and ensure that that they help to create greater awareness and potentially stimulate discussion.
This is Leah. I would just add one thing, which is that I think part of the next step from the perspective of the committee is also to turn the report into more digestible, manageable papers, documents, shorter reports, so to speak, or even editorials that then would hopefully be able to turn it. It's very dense. If you've downloaded it, you can see it's very dense, full of references, and it's pretty thick in terms of reading it through. But if we can make it easier to get the message out, that's our goal over the next year, I would say.
And one of the questions along those lines is financing is vitally important to achieve the recommendations. So apart from waiting for financing, are there any ideas that you can recommend? And you mentioned different other sources on governmental sources of funding. What can be done to achieve adequate financing for the recommendations you proposed in the report?
I'll start. This is Amy. I think that there's actually a number of different pools of financing out there, and some of the most effective ways of helping ensure that that funding is appropriately kind of targeted and structured is about having that both the compelling story and the evidence to justify that investment. And so I think the more that we as a community can be doing to come to the table equipped with those that kind of economic rationale along with the health impact and the social rationale, this becomes very important. At the national level, ministries of finance have funding frequently, especially for those in the low middle income bracket, and they often are frustrated that their ministries of health are not able to make the kind of compelling financial story with the strong justification for increased funding. And so helping to support partners in countries to be tapping into domestic funding is very important. Helping look at some of the existing entities from the World Bank and its support in, which is quite significant for global health priorities identified by countries, or national health priorities identified by countries, to Gates Foundation, to Gavi and Global Fund, to smaller foundations. Again, they're all looking for the strong justification about why investing in that $1 in whatever the specific topic is a best use, not just a good use, but the best use of funding, that it will have maximum impact. And then I would say that third bucket, there's a whole new pool of funding that we've yet to figure out how to tap into, but this growing pool of impact investors and sort of new inherited wealth of a group of people that tend to be more socially oriented that are even more demanding of really robust evidence around the value of investing their dollars into this type of development. And so that would be my biggest message back. There is funding out there. We need to be sharper on how we target it, justify it, and then ensure it's spent wisely.
So the next question, thank you so much. The next question really deals with priorities, and there's a few questions dealing with it in two buckets. One is with respect to U.S. Congress, what are the 2 or 3 greatest priorities that you can recommend to Congress? And the other was with the election of Dr. Tedros as the new Director General of the WHO. Which of the 2 or 3 priorities would you suggest would make sensible partnerships with the WHO, that the WHO ought to champion with the new DG?
This is Mike. I think that we debated and discussed at great length various areas in global health and decided that the 4 that are outlined in the conceptual model slide and as reflected in the report were the 4 that we felt deserved the highest priority by the U.S. government. This is not to say that other areas are not important, but this report was directed toward the U.S. government. That was the charge we had. And these 4 are not listed in any order of priority. They're all important. Certainly global health security, the continuing threats, mothers and children, and non-communicable diseases are all areas that the U.S. government, to different degrees, has been supporting. They are also key areas within WHO, and I would think that the U.S. government would want to discuss with the new Director General collaboration in any or all of these areas because of their importance, not just to the U.S. but to the world at large. I want to repeat again, this was not meant in the book. In our report, we did not try to cover all aspects of global health, but did focus on what we felt were priorities directed at the U.S. government in the past and in the future.
Great. Thank you very much. Clinical trials, there's a question that's come through in terms of engaging in clinical trials abroad. Can you share some of the barriers and some of the solutions to overcome those barriers to engaging in clinical trials abroad?
Yes, this is Amy. So there's the capacity in countries, and I think what we had a great deal of discussion around was both the human capacities, the actual trained personnel to be doing clinical trials, as well as often the infrastructure, and here was most notably the lab capacity, is often. It varies widely from country to country, but in many of the countries where these diseases are most endemic, it can be very weak. And the U.S. has been working to create partnerships, particularly Fogarty Center, and also USAID, between academic institutions, partners that are driving clinical trials within the U.S. with entities in country as a way to both ensure that this important work is being done and to be building capacity at the same time. So we are looking to see how can we sustain and actually increase those type of programs that leverage the kind of know-how and knowledge that we have here in the U.S. and help ensure that it is leaving behind a sustained both human and infrastructure base in these key countries.
Great, thank you very much. And just along those lines, thanks for mentioning the Fogarty International Center. A lot of the listeners may not know that Fogarty, the smallest of all the NIH centers, was slated to be eliminated in the president's skinny budget. Can you share with those online the importance of Fogarty as a foundational institution to global health efforts across not only NIH, but in a more broader sense?
Well, sure.
You want to take this?
Yeah, sure. I mean, the Fogarty Center has been around for 50 years and has been a key supporter of capacity building in countless number of countries in the world. And through that capacity building has allowed for not just clinical research, but epidemiological research, behavioral research, ethics research, research of a broad nature to take place. One clear example of that is in the HIV field, where if one looks today, where historically and from today backwards, the places in the world where we're doing a lot of trials of drug therapy or of microbicides or of vaccines, these institutions, many of them in the 80s and 90s, received grants from through the Fogarty Center that enabled them to build capacity so that they were able to do the kind of research that they're doing now. There are other examples, but the AIDS one is the best as an example. So Fogarty, as you say, does not have a large budget. It is a relatively small budget, but it is critical across the disease spectrum in capacity building. If it wasn't for Fogarty Center, I think it would be very difficult to make the achievements we've made against a number of health problems that we mentioned in the report, but even ones we didn't mention in the report.
I would just add, at Berkeley, just to add about Fogarty, not only do they do capacity, not only does it fund research outside the United States, but there's a big program bringing professionals to the United States. For example, at Berkeley, we have several who come every year, doctors from countries around the world who come and get a one-year master's in public health and then return to work in their country. So that's I think the big role of capacity building that Mike was talking about too.
Indeed, they've trained thousands of researchers all over the world that become a vital part of other countries' health systems, and they punch well above their weight. A couple of questions on universal health care and One Health. Can you share with us what the views of the committee members were on advocating for universal health coverage, as well as the importance of One Health as a mechanism to prevent spillover and zoonoses? Thank you.
Well, on the One Health, if one takes a look at the report, the concept of One Health, that is the interaction between human health, animal health, and the environment, agriculture. I mean, this is a key part of our efforts, have to be a key part of our efforts in global health security. And is certainly cited in the report as a very, very important area. It is an area that goes beyond human medicine. It really requires participation of veterinary medicine, veterinary health, agriculture, and so it's a very broad field that has gained a lot of attention in the last decade as a result of the various emergencies, disease emergencies that have come up, but it needs to continue to be given priority if we're going to seriously take on the global health security threats. I think that's unquestionable, and it is pointed out in the report. With regard to universal health care, this comes up in various areas of the report. Obviously, we need to strengthen health systems to be able to have surveillance for global health security. We need to strengthen health systems to deliver maternal and child health care. We need to strengthen health systems to reach those that are who are not HIV, don't know their HIV status or aren't receiving any retroviral drugs. We covered that area throughout the report because it's so vital to many of our recommendations.
Can I also add that universal health coverage is very much part of a financing mechanism as well, and is a way that many countries are choosing to structure their financing for the population and ensure that it is indeed universal for the country. And so we felt we commented very strongly on the importance of supporting country level ownership and supporting countries to be having a sustainable financing mechanism as they took on more and more of that financing responsibility through domestic means. And so in that vein, we weren't specific on universal health coverage, but highlighting that as being, it is one of the most critical tools that countries are using to ensure a sustainable financing mechanism to address the needs of the population.
Great, thank you. The reoccurring theme throughout the report was, and you continue to bring it up very eloquently, was the need to address the human resources deficit in low-income countries in particular, although it affects every country, mostly every country in the world. Can you give us any guidance in terms of how you recommend operationalizing a mechanism to strengthen human resources, not only in medical skill sets, but also non-medical skill sets? What partnerships or collaborations do you see could be useful in training, retaining, and sustaining health HR capabilities in developing countries?
This is a big question, so I'm sure we'll all have something to respond on this, but I'll start with one piece of it, which is that the capacity of healthcare workers and the healthcare system in countries is where, one of the reasons we focus so strongly on this issue of integrated systems and investing in platforms is because for the health worker, they are addressing all health diseases. They are not focused on a single vertical disease. And often when our funding comes, USG funding comes in very fragmented, siloed ways, it actually does not end up supporting the healthcare system and the healthcare workers and their capacity to deliver healthcare in the way that's necessary. And so we see it as a fundamental component for achieving this more sustained platforms and why longer-term investment is needed. One specific example, I think, as we look at something like digital health, how we use information technologies. This is a technology that can be providing healthcare workers with immediate capture of data, ability to layer multiple data sets together to see what is happening in a community or in a region of the country, an ability to actually visualize that data in a way that enables that healthcare worker to have the information at their fingertips and be able to understand what it's saying and be able to act on it within their scope of control. And so that rather than data being extracted as it is right now, where healthcare workers are just providing data up the chain and they never see it again and they never get the information they need to be informed about what is happening in their area and to be able to act on it and see the results of that action, something like digital health can have a tremendous difference in building up their capacity and ensuring they continue to be informed. However, the way we're applying digital health right now with these one-off apps that are focused on a single disease is missing that opportunity. And in fact, we even have the reverse situation where healthcare workers are complaining that they have so many of these one-off little apps that it's useless to them, and in fact is absorbing more time than it's worth. And I personally had the experience of seeing one health worker open their drawer and show seven different flip phones, each with its own unique a disease-specific app on it, and they just shut their drawer again and said, just cannot cope with this. So this is why we are promoting sort of a bigger integrated investment in this platform, so that the power of this this technology, of this innovation, can actually help to be building up the capacity and supporting the capacity of health workers.
I think, Amy, you covered it very, very well, and I think the digital health platform, but other platforms in healthcare, we try in the report to show examples of that. Certainly within the PEPFAR platform, we gave examples in the report of how the PEPFAR platform is used for cervical cancer, for even cardiovascular disease. I think this is really why we emphasize in the report so much that of country ownership, of country financing in the next decade. With less bilateral aid, countries really need to take that ownership and drive their systems in ways that are best to accommodate their needs.
Thank you very much. So this is a recommendation that comes from our listeners, and the Center for Global Development put out, Amanda Glassman and her team, a very good book on saving lives, and they aggregate good practices. So one of the suggestions from one of our listeners is recommendations is that if the academies would provide and aggregate case studies of best practices that they can aggregate to parallel this report. It's a suggestion that people are finding could be very useful for individuals to learn from. So a question along the lines of NCDs really relates to rebalancing. NCDs gets the run to the litter in terms of funding. Can you provide any recommendations or suggestions beyond what you stated today about how the Centers for Disease Control can be supported to do the work that they're doing, and how you see the U.S. relationship with developing countries to deal with NCDs, as you mentioned, affects them disproportionately?
This is Mike. I think the issue we discussed most about NCDs was how often reports have come out that illustrate the severity of the problem, call for action, and yet very little happens. The committee was well aware of that, and what we did in the section here in the report was to say to ourselves, what are the things that are highest priority that can be done most easily and are not terribly expensive? And I think Leah in her presentation certainly covered those. I think the branding of NCDs and thinking of all the NCDs at times overwhelms governments and overwhelms policymakers. And I think what we call for in the report is prioritization. It may not be that every country picks hypertension and focusing on behavioral risk factors and prevention of cancer through vaccinations, early treatment of cervical cancer, but it seemed to us that those were the ones that one could act on now and at least get things moving, get the ball moving in the area of NCDs. They are neglected, and it is shameful, particularly when so much can be done. 40% of in some countries even higher, of the world's adult population are hypertensive, and that's a disease that we can do something about relatively cheaply.
I can also add just some examples from the report, combining the recommendation to have more case studies, which I think is a great idea, and give you a few examples that we presented. One, for example, in Cambodia, which struggles with increasing burden of chronic disease, so 12 to 15% of the population is hypertensive. And so to address this issue, the Cambodian Ministry of Health established clinics to integrate the chronic care for hypertension and diabetes with HIV care, which resulted in increased inflow of patients and also improved health. So we have examples from South Africa and Zambia, in addition to Cambodia, in which the screening for the non-communicable chronic diseases occurred piggybacking onto the existing HIV programs. So this is why one of our overarching themes is really this integrated care. So instead of saying, let's set up a whole different system for NCDs, it's saying, look, we are getting people into the clinic anyway. Let's figure out a way that we could screen them and use the fact that they're here already, and then go from there, as opposed to imagining that it has to be a whole separate enterprise. So you can see that in the report itself. There's some more description and examples there that may answer your question.
Great, thank you very much. So just to all of our listeners, we've got hundreds of people still listening, and the committee members have been kind enough to go till the quarter after the hour, so we're going to continue for another 15 minutes. One of the suggestions was to share this report through different health associations. We're going to do that at CUGH, but is there a thought from the academies that this report would be disseminated more broadly through different other organizations that can use it?
I'm sure there is. I think that, as Leah said before, we need to do that, not just distributing the report, but it's been suggested to the committee that we prepare separate papers, monographs, addressing specific aspects of the report, and we would welcome any opportunities that people can think of, your listeners can think of, to disseminate it. There are people on the call from the Academy, and I'm sure they're listening.
And I know any organization is very welcome to help play a role in that. I know that my organization, PATH, is helping to support sort of broader dissemination of the report, and I believe the academies would welcome any other organizations that want to help support that.
Great, thank you. Dr. Norm Coleman from the International Cancer Expert Corps, doing great work trying to provide access to radiotherapy for a fixed number of malignancies in low-income countries. Wonders if this report, how it would be received in developing countries with respect to recommendations given from the United States to developing countries. Do you get a sense of how this report may be viewed in its recommendations? Would it be viewed as somebody from afar telling them what to do? Or have you found some positivity in its receptivity?
Well, the report's only been out a week, so it's a little hard to know how well it's been received, but I want to emphasize that the charge to the committee was primarily to write a report directed at the United States government. Of course, we had in mind that the report would hopefully be of relevance to other countries, but it's important to recognize that the audience of this report was the U.S. government, and in no way were we intending to suggest that any country had to follow what's in the report per se. Certainly, we hope there are aspects of the report that will be helpful to low and middle income countries in all the areas that are covered. But again, this was a report with a clear, the committee had a very clear audience in mind in writing the report.
Thank you very much. And this is a strategic and tactical question that comes up all the time. With regard to the domestic health care cuts here in the United States, what argument are you posing, and I think you've addressed this well, but perhaps you can reiterate a few of the key points, the arguments that you're posing to congressional leaders who may be thinking really largely through a domestic lens. What are you saying to them to support these investments in global health?
I think that the report is very much structured to highlight that global health and global health security is U.S. health security, that the U.S., that with the increase in transportation, with the wide rise of mobile people, that for the U.S. to protect the health of its own population, it also needs to be helping to ensure that diseases are controlled around the world, are prevented, or rapidly responded to around the world. I think we also acknowledge in the areas that we were looking at for productivity, enhancing productivity and economic growth, is that in addition to the health value and the social and moral importance of helping to support health around the world, this is also about building stronger economies and trading partners and countries which are where their own economic growth is such that there's less need for development investment. And so we do see this as having both a very strong economic argument as well as a health security in the U.S. argument, as well as opportunities for kind of growth and trade.
And Keith, I would say, as Amy has nicely summarized, healthy nations are more stable nations politically, and healthy nations are better economic partners for the U.S. I think those are key messages that we hope the U.S. Congress will resonate with the U.S. Congress.
Well, certainly the recommendations you've suggested would make the United States stronger, healthier, and more prosperous, and to not do them would make it weaker, sicker, and less secure. Our friend Dr. Zulfi Buddha has a wonderful idea and wonders whether or not there's an effort by our national academies to work with other academies and scientific organizations around the world to collaborate as a united front to be able to articulate and advocate for the recommendations in the report.
I don't know if anyone is on from the Academy who can speak, but I am aware that the Academy does have a program, one program I know that it has with African academies in African countries, where it does just that. I don't have the details with me, but I know the Academy has reached out to a number of African nations in that regard.
Hi, this is Julie Pavlin from the National Academies. Actually, that program has recently ended, but after very successful merging, and we still do partner with many of these national academies around the world. We have some efforts ongoing in different aspects of global health, working with the International Association of Academies, and so that's a great recommendation, and we will continue to proceed with that as we work with this. One of our next upcoming studies will probably be kind of taking this a little bit further and looking at quality of care as well around the world.
Wonderful. Thank you very much, Dr. Pavlin. From Absera, he brings up the good point of using that global health is really it can be used as global health diplomacy and soft power to be able to prevent conflict. Can you address a little bit about the power of global health diplomacy, global health as a mechanism to deal with the antecedents of conflict and insecurity?
Well, as I mentioned, that is certainly covered in the latter part of the report as a critical element of our global health leadership. I think there was a feeling that should definitely be, the committee definitely felt that should be maintained, but one of the, as I mentioned earlier, one of the real priorities was to build up a cadre of public health, global health experts, both at HHS and state, who saw this as a career path. The lack of that existing has been a problem when we have needed capacity, particularly in emergencies. There is a health attaché program which exists in a few embassies in the world, but there are very few. And we did discuss and learn about that program, but the main recommendation we had, as I stated earlier, was to strengthen both HHS and state in this regard. I think if we're going to practice global health diplomacy well, we need to have the manpower domestically to be able to do that.
Great. Thank you very much, Mike. And I just wanted to I'll just mention a couple of things that were here and give you all a chance to take a couple of minutes to wrap up if you had any final thoughts. So we'll go in the same order that we started, Amy, Leah, and Mike. And before you mention that, I just want to say that a core group has 200 organizations involved in global health would be a good way to disseminate, as well as, of course, the American Public Health Association. And, of course, we at the Consortium of Universities for Global Health have 157 institutions around the world in a network of 30,000. We will be sharing this information widely on our website within the next 48 hours. So those of you who couldn't get to it, you'll have a chance to see it on our website, CUGH.org. And don't forget, please, for all of our listeners, to share this webinar and the Academy's report that you can get off the National Academies website. Please make sure that you can share it through your social media platforms. The National Academies is NASEM _ Julie, you can tell me what it is. Health. So NASEM _ health, and CUGH's is CUGH News. So just for some final thoughts, Amy, Leah, and Mike. Amy, do you have any final points you want to make?
I know I would thank CUGH so much for hosting this this webinar and having this opportunity to talk with this global health community. And I guess my main ask would be is asking each of you if there are ways that this report can be helpful in terms of stimulating discussions, helping raise awareness. We look to you and to your suggestions about ways that we can most effectively use it in this window of time that we have, probably over the next month or two, when it might have most impact.
Thank you.
Yes, and I would just
Leah?
add to, yes, thanks. I would add to Amy's comments to say thank you, everybody who's been on the call and been to CUGH for organizing. And to add to the request about dissemination, which would be to say what forms of dissemination would be useful, what types of reports, what types of analyses, would it be editorials or research papers, or what form that would take. We would love those kinds of suggestions and recommendations and partnerships where possible. So thank you very much.
Thank you, Leah. Mike?
Well, I guess I also want to thank everyone and just make two quick points. One is, as Amy pointed out, the next month is important to disseminate this, and anyone on the call is welcome to disseminate this report to their representative or senator, since this will be a time of budget, and we try here to make a strong case to the U.S. government for supporting global health. And secondly, Amy said this a few times, but slide 8, this conceptual model, I think it's important in this report. There had been 2 previous reports on global health, one in the late 90s and one in about 7-8 years ago, that did a similar review of the field and made recommendations. I think one point, again, to emphasize is that we tried to focus on the priority areas, but we also looked very hard at the cross-cutting themes. And I think with the arrival of the SDGs, more emphasis on domestic resource mobilization and country ownership, the areas in that slide, the cross-cutting areas of innovation and smart financing and leadership are really going to be important and need to get the same amount of attention that the individual areas are getting. So thank you all for listening.
Thank you, Mike. So I'd like to thank again Amy Batson, Chief Strategy Officer for PATH, Leah Fernald, Professor at the School of Public Health, University of Berkeley, and Dr. Mike Mearson, Director of the Duke Global Health Institute. I'm Keith Martin, Executive Director for CUGH, and I'd very much like to thank the team at the National Academies, Dr. Julie Pavlin, Ishan Kandikar, and Elaine Hines, and here at CUGH, Karen Lamb, for running this webinar. This would not have happened without you. I know to all of our listeners that this report, the report you can find again on the Academy's website. It'll be on CUGH's website, and this particular webinar, along with this presentation, PowerPoint presentation, will be on CUGH.org. Investing in global health is an investment in everybody's future. It'll keep not only the United States healthier and more secure, but to not do this, to not invest in NIH, CDC, USAID, HHS, the Environmental Protection Agency, and the National Oceanographic and Administrative Agency, amongst others, would really compromise the health and welfare of people here in the U.S. and around the world. With that, thank you very much to all of you who tuned in today to listen to this webinar, and we look forward to hearing from you and for you attending future webinars. Thank you very much.